and good evening, everyone. I welcome you all for today's webinar on Meet the Experts on Oncology Treatments Update 2024. And for the first talk, I would like to invite Dr. Prashant Kumar, who is Senior Consultant Medical Oncologist at HCG Kolkata, for his talk on how to proceed lung biopsy principles of molecular and biomarkers analysis. Over to you, sir, for your talk.
Thank you very much. So, please on-share this screen because I'm trying to share my screen.
Sir, now you can share your screen.
Okay. Now it's visible. My slides are visible.
Yes, sir. Just make it on full screen.
Yes. Okay. Thank you. So these are the contents I will discuss one by one. What is the epidemiological data, lung cancer in India, biomarker testing, evolution of biomarker test in especially non-small cell lung carcinoma, what was the testing methods in past and in current era, and in the last, the key takeaways from this presentation. So what is the burden? According to Globocon 2000, out of all the new cases detected in that year, almost lung cancer was the fourth most common cancer across the gender, and in male, it is almost second most common cancer, accounting for almost 8% in male malignancies, and overall it is almost 5.5%. So almost every year, more than 70,000 new cancers are diagnosed, and out of which 66. So we know non-small cell lung carcinoma, almost 50% of non-small cell lung carcinoma have some biomarkers, positivity for biomarkers, and some of them have an FDA-approved agent against these targets. And these are the biomarkers including ALK, EGFR, ROS, BRAF, HER2/neu, EGFR exon 20 insertion, BRAF, RET, NTR. So all these biomarkers, we have some potentially targetable therapy, and in against some of the biomarkers now, and some of the therapies are on clinical trial. So almost 50% biomarkers or targets are actionable. So what is the importance of doing this biomarker? Because historically it has been seen that in several trials, patients identified with actionable mutation and who received targeted therapy, and when compared with those who not received targeted therapy, the median overall survival was significantly better. In the right side, in the Kaplan-Meier, you can see the blue line, and the median was significantly improved when compared to no targeted therapy. So that is the reason why most of the guidelines, ASCO, NCCN, ESMO, and CAP guidelines, they recommend at least all the biomarkers against which or against those we have approved agents like EGFR, ALK, ROS, BRAF, MET, RET, NTR, or KRAS. So even some of the guidelines like NCCN and CAP have recommended KRAS mutation as because the KRAS mutation indicates poor prognosis. Patients with KRAS mutation are unlikely to benefit from other molecular testing. So what are the methods of testing these biomarkers? These are the tissue testing methods: DNA sequencing by NGS or PCR, or RNA sequencing, or IHC or FISH. So DNA sequencing or PCR, they detect insertion point mutation, deletion. So they usually detect the aberration in EGFR, KRAS, BRAF for two new mate. Either you can do single gene or full NGS panel. Whereas RNA sequencing panel is more sensitive for fusion abnormalities, and and it is more sensitive for all cross one rate and NTRK. Similarly, FIS, ALK and ROS, these are the fusion abnormalities, and FIS is more specific or highly specialized test, can be a faster test, and IHC can be used as a screening method. Even IHC has a very good concurrence rate with FIS. So nowadays, we more often use IHC than the FIS because it is easier and we can get or faster cat than the FIS. And PDL1 is detected by IHC. So now coming to the evolution of biomarkers in non-small cell lung carcinoma. So this is the journey, tissue journey biopsy to analysis. Whenever a patient diagnosed with non-small cell lung carcinoma, we try to extract the tissue or tissue fluid. Biopsy methods and specimen processing is important. Tissue is always preferred either by resection, excision, or small tissue biopsies. And whenever tissue is not possible, even we can have high needle aspiration or exploratory cytology from urine, acid fluid, pleural fluid, sputum, or CSF. So that from which we can prepare the FFP block, and from that we can extract the DNA or RNA for the analysis. And liquid biopsy, whenever there is tissue, we cannot obtain a tissue, then liquid biopsy is an alternative option, either from blood or fluid or cystic fluid. So liquid biopsy is an alternative option, and it can be used as a complementary, though it cannot completely replace the tissue. So biopsy is very important for establishing the diagnosis and monitoring of the response also is very important. So it can biopsy helps in establishing biopsy in histological subtyping. So histology sometimes just like previously we are treating based upon histological subtypes, squamous or non-squamous, or large cell carcinoma. And for biomarker testing, whether we should take tissue from primary tumor or metastatic tumor. And it has been seen that biopsy from metastatic or primary are equally suitable, but bone biopsy should be avoided because it can be suboptimal due to decalcification or degradation of DNA. And decoded biopsy is another option. So testing methods should include all these biomarkers. Against those, we have approved targeted or therapies, and these include EGFR, cross, BRAF, NTRK, rate, MET-exon 14. And ideally, a broad NGS panel is always preferred rather than doing sequential analysis in adenocarcinoma. For squamous cell carcinoma, though we recently doesn't advise this testing, but it is always considered in young never smoker or light smoker, or if say biopsy specimen is of mixed. And PDL testing is done in all subgroup of non-small cell lung carcinoma. Even if we'll get the PDL1 result, even we can get PDL result within 1 week, we should wait for the biomarker testing results. And all these biomarker testing should be completed within 10 working days of the biopsy, and it is recommended by the guidelines. Now coming to the ctDNA testing. So what is the role of ctDNA in non-small cell lung carcinoma or liquid biopsy? It helps in diagnosis and treatment selection, monitoring, prognosis, and response to treatment, progression or relapse of the disease. And ctDNA testing overcomes some major challenges as with the tissue testing, and it is minimal invasive for patients, and it takes care of the heterogeneity and tumor challenges over time. So ctDNA testing or liquid biopsy may never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients non-small cell lung carcinoma. So this is one trial even in resectable or earlier stage non-small cell lung carcinoma. This ctDNA can be used as MRD. ctDNA positive is taken as MRD, and this TRACERx study is a small study where 24 patients resectable early stage non-small cell lung carcinoma followed longitudinally after resection, and out of that 93% of patients, that means or 13 out of 14 MRD positive patients have recurrence. Similarly, 9 out of 10 without recurrence are MRD negative. So it has a very good positive in, though it is a very small study, positive predictive and negative predictive is very good. So this study ctDNA profiling was able to confirm MRD negative and detect MRD in patients who relapsed for their disease. So what is the difference or similarity between the tumor tissue and liquid biopsy testing? Because the tumor tissue though always preferred, but sometimes we may not able to get the tissue. So it is invasive surgical procedure to obtain tumor tissue, whereas liquid biopsy is easier, simple blood draw, generally 10 ml of fluid is sufficient, and repeat sampling, serial testing is challenging with variable biopsy and patient risk, whereas in liquid it is minimally invasive procedure. Biopsy, biology correlation with histology and cellular phenotype possible in tumor tissue, whereas direct correlation between ctDNA results with histology or cell type is not possible, and more reflective of tumor genomic landscape. Sensitivity and say lower tumor cell content acceptable with sensitive technique, and whereas as liquid biopsy very sensitive method required as ctDNA may comprise less than 0.1% of ctDNA. And analytical standardization using existing validated tissue processing and handling procedures, whereas standard for analytic procedure characteristic of CFR have not been established. So these are the differences, though liquid biopsy is easy and can be, whereas tumor tissue sometimes we may not get, or due to frail patient or inaccessible site, then liquid biopsy is an alternative option. So multi-gene testing for single gene testing. Nowadays, we usually prefer multi-gene testing, at least NGS or sequencing by a broad genome, broad approved therapeutic options. And by doing this multi-gene or NGS in a single test, we can get we can test all the biomarkers, whereas by doing single testing, we have to do sequential testing, and it is time consuming. Even cost wise, this multi-gene test is preferred. Advantage of as the number of clinical biomarkers are increasing day by day. So ability to evaluate all known molecular in single NGS is a major advantage. So if many molecular markers are needed, they will reduce the cost, shorter turnaround time, and lower tissue requirement. As by doing sequential or single gene testing, the tissue will be adjusted by doing 1 or 2 or 3 tests. So it is always hard to do a multi in a single sample, and may identify some new markers like PRK that could offer additional treatment option for patients. Whereas the concept of injustice is highly complex, needs expertise, and advancement in the field of NGS are evolving rapidly. So patients and clinical community must receive sufficient education in this area. So technical techniques used frequently for mutation treatment based on these mutation detection technique, single gene assay, single Sanger sequencing, viral sequencing. So all these we'll discuss in detail. And these are the trials based upon which the biomarkers and target agents has been approved. And now coming to each biomarkers one by one, EGFR mutation. The sample type used, FEV sections, breast frozen or alcohol fixed specimen, and be used for PCR-based assays. Cytology samples are also sometimes suitable by or you can prepare cell blocks are preferred. So now sometimes the question arises whether whether EGFR mutation between the primary tumor and the metastatic sites, and it has been seen that the concordance rate is very high. So concordance rate in this table you can see EGFR in the primary for metastatic tumor in same patient is very high. So you can take or you can do EGFR mutation in primary as well as metastatic site tissue. So EGFR in early lung cancer, nowadays we have the EGFR TKI has been approved in the earlier stage or resectable lung cancer as adjuvant therapy based upon the adjuvant trial. So even in the early stage lung cancer, consider adding molecular testing for EGFR mutation on the biopsy or post-surgical basis to ensure EGFR mutation results for adjuvant treatment option, at least for stage 1B onwards for adjuvant osimertinib. So advantage of NGS over PCR, and it has been seen in one trial, one study that 48% of EGFR exon 20 insertion mutation identified by NGS are missed by PCR. Out of the 17 most common EGFR exon 20 insertion variants, only 4 can be identified by PCR. So targeted PCR-based approaches for detection of EGFR variants may under-detect these exon 20 insertion events. Therefore, NGS-based strategies are preferred over the PCR. ALK rearrangement, morphological almost similar morphology of EGFR patient, East Asian, younger patient, never light smoker, and it is seen in only 3 to 4% of patients. And these are the trials correlation between ALK and the methods of testing, FIS or IHC. So which one is preferred? So between ALK, IHC, and FIS, in case studies, I both techniques for the current and published data, and it has been seen that the false positivity rate of 0.1% with FIS. So IHC is less expensive and more widely adopted. Cross rearrangement in NLC, LC. So this is the testing methods. How the you will do ROS testing. Whenever a patient diagnosed with non-small cell lung cancer, adeno or non-squamous cell, you can do ROS1 IHC or FIS. If ROS1 is positive by IHC, you can reconfirm by FIS, or you have done FIS and it is positive, then you can consider confirmation or based on that. So detection of elevated ROS1 protein level by IHC may provide quantitative screening criteria confirmation by FIS. KRAS is one of the important mediator in EGFR, RAS, RAP, make ERK pathways, and it helps in cell proliferation. So that's and this mutation is mutually exclusive with EGFR and ALK mutation and account for nearly 30% of lung adenocarcinoma, this KRAS mutation. The most common one is G12C variant, against which we have approved therapies nowadays. And these methods commonly, though multi-gene NGS panel is preferred, single gene testing is not currently recommended. And KRAS mutation has been the sotorasib is currently approved for patients with non-small cell lung carcinoma with G12C mutation. And for adagrasib now, some phase 2-3 trials are ongoing, so we can have more options like adagrasib in future. BRAF mutation, similarly, another key downstream mediator in the signal cascade pathway, and also helps in cell proliferation survival. So BRAF mutation, there are several variants of BRAF. V600E mutation is the most common, presently more than 50% of mutation cases, and the others are 600K, 466B, 469A. They are less prevalent and in seen almost 70% with BRAF mutation. So overall, BRAF mutations is 1 to 5% of patients with non-small cell lung carcinoma. And while not widely recommended, IHC and PCR are generally accepted as a single gene test, but nowadays NGS is generally used for multi-gene, so NGS is preferred. And the currently approved therapy for BRAF is especially 600E, dabrafenib, trametinib, and the other BRAF mutation, the impact of other mutation on therapy selection not well understood. Still, we are using the same dabra and trametinib in other mutation also. c-MET receptor skipping mutation and non-small cell lung carcinoma. c-MET has a normal role in emergency and wound healing, and this MET exon 14 skipping mutation is in 3 to 4% of non-small cell lung carcinoma. But when you will get a sarcomatous cancer, the percentage of c-MET mutation is almost 20 to 30%. So majority of MET exon 14 skipping mutation can be detected with DNA NGS, but it has increased sensitivity when with RNA NGS. These are the methods. Nowadays, IHC and is not recommended. PCR is DNA design dependent. RNA, there are some technical considerations. So yes, DNA is potentially detect many mutations, but RNA NGS, if available, it is more sensitive test for c-MET exon 14. Rate receptor tyrosine kinase rate fusion. It has a normal role in neuronal or genitourinary development, seen in 1 to 2% of non-small cell lung carcinoma, and majority of rate fusion can be detected by DNA NGS, but sensitivity is increased sensitivity with RNA NGS. So these are the methods. IHC and PIS can have significant false negative or false positive. So nowadays not recommended. RNA NGS high often fusion pattern information and high dependent upon RNA quality. Poor quality leads to reduced sensitivity. So majority of our rate fusions can be detected with DNA NGS, but increased sensitivity with the RNA NGS. So NTRK options of IHC, RNA, or DNA is artificial. With each of the tests has advantage and disadvantage, but RNA NGS is most sensitive, but IHC is widely available because of faster TAT. Nowadays, by doing IHC as a screening and reflex NGS is preferable because of the low prevalence of NTRK fusions. So important to qualify negative results, limitations of sample error testing. So this is an ESMO working group recommendation, and the flow diagram you can see NTRK testing. If is the histology type or known for harbor highly recurrent for NTRK fusion, then you should go for PIS, RT-PCR, or RNA. If the prevalence is low, then you can do a sequence testing by IHC, then you can confirm by NGS testing. So methods of NTRK, IHC, PIS, NGS, IHC, rapid result, detect transcribed and translated events, low cost as single test, widely available, whereas NGS potential multiplex testing, less repeat of issue, fusion partners, and position are defined. RNA is most sensitive. So choice of assay will be dependent on institution, resource, clinical context, but reflexing to NGS was the IHC reasonable for LCLC due to low prevalence. Ortho mutation seen in 3%, mostly exon 20 inframe insertion, mutual exclusion mutation. Never circle. Mutation and application must be identified using DNA NGS panel, and IHC used to assess operations in 59% of non-small cell lung carcinoma. So this is the treatment schema of advanced non-small cell lung carcinoma. If you have a biomarker positive, you will find a biomarker positive by doing broad NGS-based panel. Then,
Prashant sir, sorry to interrupt. Kindly
instead of
conclude
starting chemotherapy,
kindly conclude your talk
yes,
in 2 minutes, please.
yes. So PDL1. So these are the companion diagnostic tests. 22C3 for family pembrolizumab, SP263, SP1.2, durvalumab, adalimumab, ventana, and 28 by daconivola. So based upon that, these are the PDL1 testing differences. And biomarker for immunotherapy. This is a controversial topic. PDL1 sole current biomarker, though it is not a ideal biomarker. TMB not used or not currently used. Completing results, MSI, MMR not used. So conclusion: biomarker testing in non-small cell lung cancer has evolved from single gene to multiplex. Multidisciplinary meetings helps in better understanding. Sample should be containing adequate tumor content, at least 10%. to prevent delay. Ideal TAT is should be 10 working days, and high throughput for platforms such as NGS should be used to screen several genes. Thank you.
Thank you, Prashant sir, for such a nice talk. Any question for Prashant sir? Thank you, Prashant sir. For the next talk, I would like to invite Dr. Debapriya Mandal sir. Sir is consultant medical oncologist, SGCCRI, Kolkata. Over to you, sir. Debapriya sir. Sir, you are muted. Kindly unmute yourself.
Yes. Just give me a couple of minutes.
Sure, sir, sure.
So I'm having some issues with the Wi-Fi here. Could you just, put on the slides from your end?
Sure, sir. I'm sharing your slide.
So, good evening, everyone. Today we will discuss a brief overview of lung cancer treatment currently. Next slide, please. So, the burden of lung cancer in India, worldwide, it is one of the most common cancer in incidence as well as mortality. In India, the lung cancer incidence makes it the fourth most common cancer and also the fourth most common cause of death with cancer. Next slide, please. Next slide, please. So if we compare the HSCC 7th and the 8th edition, then we can see that there has been subtle changes, like the change in what was 2B could be now 3A, and there are also subtle changes in the T4 definition. Next slide, please. So how to investigate lung cancer to stage this? First, we have to get a chest imaging. That is, I think most patients come to us with a chest X-ray or a CT scan of thorax. And after that, the biopsy or sampling from the primary tumor is either done by a bronchoscopic guidance or endoscopic ultrasound guidance or a percutaneous CT-guided core biopsy. To stage, the preferred imaging modality is PET-CT. And when PET-CT is done, depending on certain features, a few patients will still need an invasive or semi-invasive, less invasive mediastinal staging. And for any patient who is to be considered for a curative intent therapy, MRI brain is a must. And it is not wrong to say in today's time, even in stage 4 cancer patients, because our treatment choices may be affected by the baseline brain metastasis status, it is good to get a baseline brain MRI. Next slide, please. So, what are the advantages of PET-CT? So, on CCT, we go by size. If the short axis is more than 10 millimeter, then the lymph nodes are more likely to be affected. PET-CT adds an advantage of around 10 to 5 to 10% in sensitivity and specificity, particularly in detection of involved lymph nodes. And also something that's not written in the slide here is that PET-CT outperforms conventional bone scan, the technetium 999 bone scan, in detecting bone metastasis. So lymph node and bone, these are the one of the two main advantages of PET scan. over conventional combination of CCT scan and a technetium-99 whole body bone scan. Next slide, please. So what are the risk factors for an occult into, that is mediastinal lymph nodal involvement? Mainly, the mediastinal lymph nodal involvement is seen in central tumors. Size of tumors generally seen with tumor sizes 5 or more, and higher SUV on PET-CT. So what are the ways, next slide, what are the ways we confirm the mediastinal nodal involvement? So this has to be done by a sampling. Next slide. So what are the ways we can sample a mediastinal node? One of the less invasive ways, endoscopic ultrasound or bronchial ultrasound guided FNAC or biopsy. And invasive modalities are mediastinoscopy, that could be conventional, or video assisted like VATS, VAMLA, and TEMLA. Next slide. So mediastinal staging, so we are all familiar with the ISLC lymph nodal map, the stations, and there are 14 stations, and some of them are more accessible with a bronchoscope, and some are more accessible percutaneously or through an endoscopic ultrasound. Next slide, please. So when invasive mediastinal staging is indicated, generally in centrally located tumors more than 3 centimeters size, when there is extensive infiltration, direct infiltration of the mediastinum, that would be T4, and positive N1, that is when there is ipsilateral, intrapulmonary or hilar lymphadenopathy. When bulky N2 is detected on CT scan, usually they do not require a confirmation with invasive techniques. So it's mostly to look at, PET negative mediastinum. If the mediastinum is not showing obvious metastasis on PET-CT, then only we need to confirm it through a direct sampling. So in case of discrete N2, yes, there is a role of invasive mediastinal sampling, because we need to be sure whether it is a single station resectable N2 or it's a multi-station N2, because it makes a difference in our judgment now, because multi-station, single station N2 are potentially resectable or resectable, and they may be resected upfront, one option. The other option would obviously be to get neoadjuvant chemoimmunotherapy and then go for a resection. So normal mediastinum, so ESMO, this is the ESMO algorithm. Next slide, please. The ESMO has a very beautifully given an algorithm to assess the mediastinum. So mediastinal lymph node is positive on PET-CT. Then if that is bulky or obviously looking multi-station N2, then there is no need for a mediastinal sampling. If this is a non-bulky or single station N2 on PET-CT, then first attempt should be made with an EBUS or endoscopic ultrasound. And if it is negative on EBUS, then there can be a role of other more invasive techniques. If a mediastinal lymph node is positive on EBUS, then the patient goes for multimodality treatment, that is mainly non-surgical treatment. So if a mediastinal lymph node status is negative on PET-CT, then depending on whether this is a large tumor or centrally located tumor or N1 anyway, by involvement of the ipsilateral, hilar and intrapulmonary node, then the patient should get, despite being PET negative, the patient should get a direct sampling from the mediastinum. First option is always EBUS or endoscopic ultrasound. And if that is not yielding, then only we go for an invasive mediastinoscopy or something of that sort. Next slide, please. So in this table, it's been nicely shown that different 14 stations, some are more accessible through one technique and some are more accessible through other techniques. But we obviously cannot subject our patients for lymph nodal sampling through all these techniques. So generally, because EBUS and EUS are less invasive, these are always preferred. Next. So non-invasive and invasive, we have already discussed. Next slide, please. So evolution of therapy in lung cancer. Lung cancer was thought to be one single disease, basically divided into, in few years later, they were divided into non-small cell and small cell lung cancer. Then non-small cell was further divided into various histologic types like squamous cell carcinoma, non-squamous cell carcinoma. Non-squamous cell carcinoma could be large cell adenocarcinoma and various others. Then we detected molecular pathology, which could be the underlying driver mutations like EGFR, ALK, ROS1, and more driver mutations like BRAF, HER2. And then we came to know about PDL1 expression level and tumor mutational burden, which could mean that these tumors are more amenable to treatment through immunotherapy. Next slide. So these advances in management of non-small cell carcinoma has improved the survival substantially, and that is evident in all the recent publications and also in the CR database. Next slide, please. So advances in treatment are both now seen in early stage, that is resectable disease, or even in stage 3 after chemoradiation, as well as unresectable or advanced stages. Next slide. So what are the molecular targets? The molecular targets are the commonest target in Eastern population is EGFR. Then we have ALK, ROS1, red fusion, NTRK, HER2, BRAF, and various other mutations. KRAS mutation, which was thought to be untargetable for a long time, has been targeted with a drug called sotorasib, but the results haven't been as promising as we have seen with EGFR targeting or ALK targeting. Next slide, please. So what are the adjuvant treatment recommendation? In stage 1A, there is no evidence-guided treatment, systemic therapy or radiotherapy recommended after a curative resection. Stage 1B onwards, that is tumor size 4 or more or node positive, we generally recommend chemotherapy for our patients. And in certain N2 lymph nodes, post-operative chemotherapy plus radiotherapy was recommended for a long time. But the lung art trial that has shown that even in N2, there is no survival advantage of radiotherapy in lung cancer. So the guideline mandated post-operative radiotherapy in all N2 disease, that is debatable, right? Next slide, please. Next slide, please. So resection and pathologic stage and resection margins matter. The role of radiotherapy possibly only remains in a resected lung cancer in R1 and R2 resection, that is margin positive resection. So after surgery, about 40 to 50% patients remain cancer free and 50 to 60% recur. So there is a great need of better adjuvant therapy for resectable non-small cell carcinoma that may be either neoadjuvant or adjuvant. So there is great role of unmet need of systemic therapy in resectable lung cancer. Next slide, please. So I've discussed this already that tumor more than 4 centimeter, that's a risk factor. And these are the ones which are more prone to metastasis and recurrence. So in classical trials where chemotherapy with a platinum doublet was tried in lung cancer, the cutoff was tumor more than 4 centimeter or equal to 4 centimeter. That is 1B onwards. And this is where adjuvant chemotherapy is recommended. That could be either...
request you to conclude your presentation in 2 minutes.
Sure. Next slide, please. So for the brevity of time, we'll just move over the normal chemotherapy stuff. Next slide, please. So next slide. So we'll move on to the more recent ADAURA trial, which has shown a massive benefit over the older standard of only chemotherapy after resectable lung cancer, with the adoption of EGFR targeting after lung cancer surgery in stages 1B onwards. And it has shown a reduction in risk of recurrence by 80%. So this was a very positive trial which showed that adjuvant osimertinib improves disease-free survival in lung cancer, recurrence-free survival. Next slide, please. So atezolizumab also has shown overall survival and DFS advantage of around 10 to 12% in lung cancer with a PDL1 of more than 1% when given in an adjuvant setting after surgery. Next slide, please. Lung cancer radiation has very limited role, like we have already discussed. Its role is not substantiated even in N2 disease. Next slide, please. However, as a definitive therapy, it still has role in unresectable cancers and in early stage where surgery is not possible for possibly medical reasons, comorbidities, inadequate fitness for such massive surgeries. So there is the option of SBRT, and SBRT has shown almost similar local control compared to surgery. Next slide, please. So next slide. So this requires very advanced planning, IGRT gating and all that stuff. So, however, we can see that radiation therapy as a definitive therapy in stage 3 lung cancer does not give much hope in the long term. Next slide. And that is why the need of some better adjuvant therapy after definitive chemoradiation comes in. Next slide. Next slide, please. So, the Pacific trial used adjuvant durvalumab after chemoradiation for 12 months, and that has shown a benefit of more than 10% in progression-free survival and OS. Next slide. Next slide. Next slide, please. And we have also now emerging evidence from the ALINA trial. Next slide. Yes, FLORA and ALINA. So FLORA is basically first-line osimertinib. This is not new anymore. And ALEX is first-line alectinib. So these have also shown promise. Next slide. So we have more recent information from the ALINA trial, which has shown good DFS in resected lung cancer with ALK mutations when alectinib is used as an adjuvant therapy instead of chemotherapy in resected lung cancer. Next slide, please. So we have also other options like crizotinib. Crizotinib is not recommended anymore. We have better drugs like capmatinib and tepotinib. In rate arrangements, we have selpercatinib and praseltinib available. For NTRK rearrangements, we have larotrectinib and entrectinib. For HER2 mutations, it's written in this slide aducanumab emtansine, but we have better options now. HER2 positive lung cancer, the treatment of choice now is TDXD, which is to be used either in second line or later lines. Next slide, please. So with that, every sort of improvement that we have made in the last 1 decade or so has resulted in incremental survival benefit, which is good for the lung cancer patients all over the world. So with that, I'll conclude today. It was a very brief and fleeting summary of all the systemic therapy options we have in lung cancer from early stage, locally advanced to advanced stages. Thank you.
Thank you, sir. Thank you so much for your excellent talk. So, are there any questions which can be taken from the audience? There are no questions. So, we'll proceed then. Abhimanyam, Devipriya ma'am, Devipriya Mondal want to say. Any questions from your side, doctor? No.
We move to the next session.
So next session, is the speaker there?
Yes, ma'am.
Okay. Just a minute. So I would like to invite Dr. Pradeep Kumar Mondal, who is consultant medical oncology at Medica Hospital Private Limited, for the talk on advanced EGFR-M NSCLC evidence-based review of targeted therapies. Over to you, sir.
1 minute, madam. I just share my.
Sir, can I share your slide from my end?
Okay. So please. Okay. So thank you. Thank you, medical team, for giving me this opportunity, and thanks all the delegates who have joined in this academic evening. Thank you all. So basically, today I will discuss that the most burning topics, that basically that targeted therapy, that in EGFR mutated lung cancer. So if we go through that lung cancer epidemiology, we'll see that after that breast cancer, probably in worldwide, that it is second most common cancer is diagnosed in males, and third most common cancer which is diagnosed in females. It is in global, according to the global data 2020. If we see that in Indian scenario, because that lip and oral cavity cancer taking the second most common cancer which is diagnosed in India, and followed by cervical cancer. So lung cancer is fourth leading cause of cancer related deaths in India, and overall incidence is fourth in Indian subcontinent. So if we see that almost it's comprising 5.5% of total cancer patients which is diagnosed, and according to this 2020, almost 72,000 new cancer cases which is diagnosed. And out of this, that non-small cell lung cancer carcinoma is the most common lung cancer which is diagnosed. Next slide. So if we see that relative survival rates, that is of course vary according to the stage of diagnosis. So in our clinical practice, stage 1 lung cancer is very uncommon, because in India there is no screening programs available for lung cancer. So only 1.2% patients are diagnosed in stage 1. 3.8% patients are diagnosed in stage 2, 29% patients are diagnosed in stage 3, and most around 60 to 70% patients are diagnosed in stage 4. So that almost 2/3 of our lung cancer patients are diagnosed in stage 4 disease only. And if we see that the survival, that 5-year overall survival in stage 1A is 92%, and followed by in stage 1A2 is 83%. But if we go into the stage 3C, that 5-year overall survival is only 13%. Stage 4A probably it is around 10%, and stage 4B is very less, probably around less than 5% of the patients. Next slide. Yeah. So more than 50% of the stage 4 non-small cell lung carcinoma patients have some biomarkers are positive. So there are two types of biomarkers. One is predictive biomarkers that are indicatives of therapeutic efficacy, because there is an interaction between the biomarkers and the therapy on patient outcome. And another is the prognostic biomarker that are indicative of the patient survival, that is independent of the treatment received, because the biomarker is an indicator of the innate tumor aggressiveness. So testing of several genetic mutations and PD-L1 status is recommended for most of the patients with advanced non-small cell lung carcinoma. And most of the times we prefer using this next generation sequencing to have a broader panel to have an idea about that biomarker, which is commonly seen. So if we go through the different biomarkers, you will see that that one of the common biomarker which is diagnosed in non-small cell lung carcinoma is KRAS mutation, that is almost 25%, and these mutations lead to the increased tumor cell proliferation, followed by that EGFR mutations, that is 17% worldwide, but probably in Indian subcontinent is little bit higher incidence of EGFR. So EGFR mutation drive the tumor growth and it's predict the response to EGFR TKI, followed by ALK rearrangement, that is around 8%, and different others like BRAF, rate, and all these are also approximately around 15 to 20% of total. Next slide. Yeah, so testing methodology for targetable mutations in lung adenocarcinoma. So most common that in EGFR is PCR based analysis. ALK is commonly that is either immunohistochemistry, ISC, or FIS. ROS is also through all the three, that PCR based, ISC, and FIS, the mostly ISC based. PDL1 is of course through ISC. Next slide. EGFR driver mutations in lung cancer. The most frequent EGFR TKI sensitizing mutations occur in either in exon 19 or exon 21. And if we go through that, according to that mutation-associated drug sensitivity, we'll see that most commonly that diagnosed mutation is that exon 19 deletion mutations, followed by exon 21 L858R or L861 Q mutations. In these two mutations, there are maximum sensitivity of the EGFR TKI. There are all, of course, the few uncommon mutations like G719C, G719S, and G719A. Next slide. So based on a limited number of studies, the prevalence of EGFR mutations appears broadly similar across disease stages. And if we go through the ASEAN data, that in stage 1, almost 34 to 54% patients are maybe EGFR positive. In stage 2, 24 to 47%. Stage 3, it is around 27 to 47%, and stage 4 around 30 to 48%. US and Europe, that percentage of positivity is a little bit less, as that overall estimated prevalence in Caucasian is 10 to 20%, and ASEAN is around 30 to 40%. So if EGFR TKI were available in the resectable setting, a similar proportion of patients may be able to benefit compared with the advanced setting. Next slide. Yeah, so NCCN recommends EGFR testing in early stage non-small cell lung carcinoma. So that responsiveness to oral EGFR tyrosine kinase inhibitors therapy, that most recent data indicates that tumors that do not harbor a sensitizing EGFR mutation should not be treated with EGFR TKI in any line of therapy. So molecular testing for EGFR mutations should be performed when adjuvant TKI therapy is in consideration for non-small cell lung carcinoma patients from stage 1B to stage 3A. Next slide. So EGFR activating mutations result in constant signaling by the EGFR. So if we don't block that signaling, so there will be increased transcription, increased protein synthesis, proliferation of the cell, and cell survival. So basically, by blocking this EGFR, we are basically preventing all this protein synthesis, proliferation, and cell survival. So ultimately, there will be apoptosis and there will be death of the cell. So that is the mechanism of action. So if we see that tumors usually bind to the EGFR binding domain, and there will be an blockage of that downstream pathway. So in EGFR mutated pathway is on even when the EGFR is not bound to the receptors. Next slide. Yeah, so current treatment options for advanced non-small cell lung carcinoma. So of course that we have to check for this molecular marker upfront, and if patient is having this that that biomarkers positive, according to that the targeted treatments can be planned. So like that, if patient is EGFR mutation positive, then if we have not started chemotherapy for our minimally symptomatic patient, then straightforward we can go to the first or second generation EGFR TKI, and if chemotherapy has been already started, then we can switch over to EGFR TKI. And if patient had progression on EGFR TKI, then we have to check for T790M mutations. If T790M mutation is positive, then osimertinib is the options. And if negative, then chemotherapy plus minus targeted therapy. So like that only in ROS1 mutation positive, first line treatment is crizotinib. And if a patient progresses on crizotinib, then options are that other targeted therapy or chemotherapy. In PDL1, there is a different kind of, if PDL1 is positive, more than 50% TPS, then pembrolizumab in the first line. And if patient is less than 50%, but more than 1%, that chemo plus immunotherapy is the options. For all these biomarkers negative, then chemotherapy is an option. In later lines, then we can, in second line, we can use immunotherapy. Next slide. Yeah, so osimertinib is a third generation irreversible CNS active EGFR TKI that is selective for the both EGFR mutated that or EGFR T790M resistance mutation. So osimertinib is a very selective EGFR TKI sensitizing mutation for L858R or exon 19 deletion mutation, and also for T790M resistance mutation. So it works is a broad acting EGFR TKI. So it works on both that sensitizing mutations like deletion 19 and L858R, and also it inhibits the T790M mutations, and it has very lower activity against that wild type EGFR, so toxicity is a little bit less, and it crosses the intact blood-brain barrier as seen in that preclinical model. So it has very high activity in the CNS. Next slide. Yeah, so FLORA is the trial. It is a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TKI as the first-line treatment of patients with locally advanced or metastatic EGFR mutated non-small cell lung cancer. Next slide. Yeah, so in phase 3 double-blinded study, it was conducted in 29 countries and 132 sites. So if we look into the eligibility criteria, more than 18 years patient with good performance status with advanced metastatic non-small cell lung carcinoma with exon 19 deletion mutations or L858R without any prior systemic treatment patients were randomized 1:1 between the two group, osimertinib 80 milligram daily. Total patient was 279 compared with EGFR TKI of standard of care like gefitinib or erlotinib. So total number of patients was 277. Stratification factor according to the mutation and race of the patient, that is the Asian versus non-Asian. So so after that every 6 weeks that patient was assessed for disease evaluation according to the RECIST criteria. Until that objective progression of disease, the treatment was continued in the both the group, and crossover was allowed in patients with confirmed progressive disease according to the blinded independent central review on the standard of care, and T790 mutations may begin post-progression open label osimertinib. Primary endpoint of this trial was PFS based on the investigator assessment, and secondary endpoint was the objective response rate, duration of response, disease control rate, depth of response, overall survival, patient reported outcomes, and safety. Next slide. Yeah, so in the FLORA trial, baseline characteristics were balanced according across the treatment arm. So if we see in that male and female ratio, that female patient was more in the both, almost 60% patient was female. Median age was around 60 years. That white, that Caucasian was around 36%, 62% patients was Asian. that mostly never smoker 65%, CNS metastasis upfront was 19%, 19% in the osimertinib, and that 23% in the other group with good performance status, mostly that PS1 60% patients. Histology adenocarcinoma, mostly adenocarcinoma, 99% patient adenocarcinoma, and deletion 19 deletion mutation was 63%, 37% patient had L858R. Next slide. Efficacy primary endpoint, that the PFS by the investigator assessment. If you see that median PFS was 18.9 months in the osimertinib versus 10.2 months in the standard of care, with an hazard ratio of 0.46. So almost 54% reduction in the event in the osimertinib arm. And if we see that there are very early separation of the curve within 3 months, and if we see that at 12 months and 18 months and at 24 months, there are significant separation of curve between the two groups. So osimertinib reduces the risk of progression and or death almost by 54% compared to the standard EGFR TKI. Next slide. Yeah, so forest plot, it has been shown that a consistent benefit of osimertinib over the standard EGFR TKI in all of the subgroups. So if we see that in female patients, it had better response. In non-ASEAN had better response than ASEAN. In non-smoker, better response. In CNS, even if patient has CNS metastasis, it has better response and it favors over standard of care. And exon 19 deletion mutation had better than that L858R. And EGFR mutation by ctDNA positive subgroup had better response. Next slide. So if we see that objective response rates, that there was significant disease response is almost 80% in the osimertinib versus 76% in standard of care. At more than 6 weeks, stable disease of 17% in the both the group. But if we see the progressive disease, it is higher in the standard of care compared to that osimertinib. And if we see the duration of response in osimertinib, median duration of response is 17.2 versus 8.5 in the standard of care. And duration of response was almost twice as long in patients treated with osimertinib compared with that comparable EGFR TKI. Next slide. So FLORA overall survival final analysis at 58% maturity, that osimertinib overall survival of 38.6 months versus comparator EGFR TKI 31.8 months. The final analysis of the OS demonstrated clinically meaningful and statistically significant improvement with osimertinib when compared to that EGFR TKI. So with an overall survival OS hazard ratio of 0.79, so almost 20% improvement in the overall survival when compared to that comparator EGFR TKI. Next slide. Yeah, so if we go through that FLORA adverse event summary, that it was almost comparable between the two groups. If we see the rashes is higher in the comparator EGFR TKI, almost 79% compared to 59% in the osimertinib. Diarrhea is almost similar between the two groups. Nail effects is similar. Dry skin is similar. Paronychia is almost similar. Stomatitis little bit higher in the osimertinib compared to that comparator EGFR TKI. Anorexia, cough, it was almost similar. Nausea, AST/ALT changes was significantly higher in the comparator EGFR TKI and compared to that osimertinib. Next slide. So any grade adverse effect was 97% in the both the subgroups. Any adverse effects of CTCAE grade more than equal to 3, it was 33% in the osimertinib, less than the comparator EGFR TKI. Adverse event leading to death is only 2.2% in the osimertinib, and any severe adverse effect it was 20% versus 25%, and adverse effect leading to discontinuation of the treatment is only 13% when compared to 18% in the standard of care group, and any other significant adverse effect was 55%, comparable with the standard of care. And adverse effect possibly causally related. Any adverse effect CTC greater than equal to 3 in osimertinib, 17 versus 28% in the standard of care group. Next slide.
So I would request you to conclude your presentation in 2 minutes.
Okay, thank you. Next slide, please. So FLORA's summary, osimertinib resulted in a highly significant, statistically significant and clinically meaningful improvement in the PFS over standard of care, hazard ratio of 0.46. So 54% reduction in the progression or death, and consistent benefit was seen in all predefined subgroups, including that CNS mets group. And there was almost doubling of the duration of response with osimertinib. And in overall survival also, there are significant meaningful improvement in the OS with an hazard ratio of 0.79. And there is comparable safety profile of osimertinib to the standard of care, and overall lower rates of grade 3 or grade 4 toxicity in osimertinib group. So osimertinib is now the standard of care first line therapy in patients with EGFR mutated advanced non-small cell lung cancer. Thank you.
Thank you, sir. Thank you for your excellent presentation. And as we move forward, I would like to invite Dr. Varun Goyal, who is Senior Consultant and Principal Coordinator, Daycare Services, Medical Oncology at prestigious RGCI Hospital, Delhi, for the talk on exceptional response to osimertinib EGFR metastatic NSCLC. Over to you, sir. Over to you, Dr. Varun.
Yes. Just sharing my slides.
Sure, sir.
Sir, kindly make it full screen.
So my slides are visible.
Yes, sir.
So good evening, everyone. First of all, thank you, organizer, for giving me this opportunity, and thank you, AstraZeneca, for this sponsoring this talk. So topic given to me today for discussion is about the exceptional response to osimertinib, especially in EGFR mutation positive advanced and metastatic NSCLC patients. So I will talk about some real case scenario with some case studies, and we will see some real world data, how FLORA trial results have been incorporated in our clinics, and we have seen even better results if we compare from the FLORA study. So in October 2020, Mr. X, so he's a 64-year-old gentleman. He presented with coughing and progressive dyspnea and severe backache. So within last 10 days, he had complained that he could not walk without support, and there is giddiness since last 5 to 6 days, and significant weight loss of 5 kg in the last 1 month. As such, he is non-smoker. So obviously, smoking history is important because in smoker, if any lung cancer there, then more likely chance of having small cell lung cancer, or obviously it is not a 100% correlation, but it is there will be more chance. But in a non-smoker and in middle age group, not old age group, so there may be chance of non-small cell lung cancer and having adenocarcinoma. So in this patient, initially chest X-ray and then CT scan and then finally PET scan have been done. So PET scan is showing mass lesion in the right upper lobe with hilar nodes of around 4 into 3 centimeter size. SUV was 19, and it is disease not only in the lung, it has already spread into the multiple bony metastasis. So then biopsy was done from the lung mass. There was no other visceral lesion, no supraclavian lymph node or liver lesion. So directly bronchoscopy guided biopsy from the lung mass was done. And on histopathology, it is adenocarcinoma after ISC, which is stated here, that is TTF1 positive and napsin positive, and negative for P40. So on molecular analysis, because nowadays dictum is that every patient of lung cancer, we should go ahead with the NGS. Initially, we may do EGFR by RT-PCR and ALK by ASC, because because of some availability issue or affordability issue, or in any case, NGS report may take 10 to 14 days at least. So we may do initial EGFR and ALK if patient is symptomatic. If patient is not that much symptomatic and can wait for 10 to 14 days, we can just go for NGS. But still, here on molecular analysis, he got found to have EGFR exon 19 mutation positive, and other mutations like KRAS, BRAF, MET-exon, ALK, ROS1, HER2, all were negative. So this happens most of the time, that all of these mutations are mutually exclusive. So if any one mutation is there, then other genes mutation are usually not there. But a few rare cases, we may see combination of these mutations also. So here, this patient is PDL1 negative, so there is no confusion because sometimes we may see patients of driver mutation positive with PDL1 positive. So, and we may get confused which drug we should use first. Although there is no confusion, if driver mutation positivity is there, we should use TKI only, and because those patients will not be that much responsive to PDL1 inhibitors, IO agents. In the later lines, maybe we obviously will use IO agents, but initially in the front line, we have to use TKI only. So because patient is already showing symptom of dizziness, so MRI brain also have been done. And because in PET scan, we know that brain imaging is not that sensitive and we may miss things. So in MRI, there is multiple ring enhancing lesion in the cerebellum and cerebral hemisphere with significant perilesional vasogenic edema, which we can see in this in this picture very clearly. So on the other hand, if we may see one other patient like there is no CNS symptom, no dizziness, no vertigo, no headache and all, even then we should do MRI brain upfront as a staging workup. So obviously this point have been discussed multiple times in various meetings with our colleagues, but even asymptomatic patient, we should do MRI brain upfront for the staging workup. Although it may be that if patient is non-symptomatic, we will not do any radiation or something for that patient, especially if patient is driver mutation positive. Because if we use TKI to those patients, then those brain mets will be tackled by those TKI only. So final diagnosis for this patient have been made stage 4 NSCLC with exon 19 del mutation with brain and bone mets adenocarcinoma. And because patient was symptomatic, although I have told you patient was not symptomatic, we straight away can go for EGFR TKI to treat these EGFR mutation positive patients, these EGFR mutation positive patients. But initially in this patient, local radiation therapy for brain mets have been given. After that, patient was put on EGFR TKI. So which EGFR TKI? We have available options of 5 drugs. First generation, second generation, third generation TKI, gefitinib, erlotinib, first generation TKI, afatinib, dacometinib, second generation TKI, and osimertinib, third generation TKI. So, although cross trial comparison should not be done, but for reference purpose and for the understanding the different drugs. So obviously all the 5 drugs are different, but PFS wise, if we see best PFS have been achieved by osimertinib in FLORA study. So it is around 1.5 year PFS, which have not been seen earlier with any other EGFR TKI. So unheard of benefit of PFS and even OS benefit have been achieved in the FLORA study. So here another point is, what about the CNS penetrability of these different first generation, second generation, and third generation TKI. So in FLORA study, in the inclusion criteria, patients with CNS mets have already been recruited, although should be asymptomatic or previously treated. But in afatinib trial, they haven't taken CNS mets patient. In decomatinib trial also. So we can see here that with these drugs, brain Cmax have been achieved best with the osimertinib, and degree of CNS penetration with individual regional distribution of this drug have been seen in different patients, that osimertinib is the best out of all these TKI, which is having best CNS penetration. So that's why in this flowchart, although I've already discussed that, we can summarize that if in a patient of newly diagnosed EGFR positive and SCLC patients, if brain mets are there and patient is symptomatic, then some form of local therapy in the form of SRS or surgery or WBRT. WBRT is the least preferable option because of the long-term side effect. Wherever possible, either left alone if patient is not symptomatic, directly go for TKI, mainly third generation TKI, because of the good CNS penetrability. Otherwise, if patient is too much symptomatic, we can go for surgery or SRS. Then on the other hand, if some financially constrained or developing countries where osimertinib patient is not available or not affording, and because of any other reason, because of logistic reasons, if patient have been started on first or second generation EGFR TKI, and then patient progress on in the brain, then if patient is symptomatic after local treatment, we can go ahead with the T790M mutation testing. So this sequencing method is mainly problematic because of this again biopsy and then checking for T790M mutation, because sometimes it is very difficult to go for biopsy again, although liquid biopsy and T790M mutation analysis is there available, but not everywhere. So, and PS also can deteriorate. So if patient have been started on sequencing strategy, then up to 1/3 of patient will be devoid of the benefit of the osimertinib, or even if those patients are T790M mutation positive. But still, if that has been done, so in T790M mutation positive patient, osimertinib can be given. Otherwise, in T790M mutation negative patient, even patients are asymptomatic for CNS disease, still SRS or WBRT have to be given. And then if systemic disease in control, after SRS or WBRT, same TKI can be continued. If systemic disease also not in control, then we have to go for chemotherapy in these patients, especially if PD-L1 is negative. So in FLORA study, if we see patients with already having CNS mets or without CNS mets, so hazard ratio is same in both the subgroups. And median PFS in CNS mets patient is 15.2 versus 9.6 months. And without CNS mets patient, it is 19.1 month versus 10.9 months. So obviously, if patient is with CNS mets, then survival PFS is less if we compare with those patients in which CNS mets are not there. But quantum benefit with third generation TKI versus first generation TKI is better, and hazard ratio is same. Kaplan-Meier plot, we can see here that both lines are well distant to each other and remaining distant for the very late follow-up. So, and that benefit is mainly because of the good CNS penetrability of this drug. So, as I've already told you that in Lux Lung studies, so median CNS PFS was 8.2 versus 5.4 months. In decomatinib studies, these patients have not been recruited and excluded from the study at all. And osimertinib studies did 15.2 versus 9.6 months. So patients with brain mets were excluded from Archer study. Intracranial CNS response was not assessed in Lux Lung 377 study. Systemic clinical benefit was observed with afatinib versus chemotherapy, but not versus gefitinib. Systemic and CNS clinical benefit was observed with osimertinib if we compare with the first generation TKI, and data on brain mets were not gathered in either the erlotinib or gefitinib global clinical trial program. So based on these discussions, we may say that this patient, because of the symptoms, have been given SRS and followed by osimertinib. What about for bone mets? Because patient was having significant pain but not localized because of the multiple bony mets. Any palliative radiation to bone have not been given. Only radiation to brain have been given. For bony mets, bisphosphonate in the form of zoledronic acid have been given to decrease skeletal irritative events like pain and impending fracture and all. So osimertinib and as a standard dose of 80 milligram per day have been given to this patient. And so all these this treatment have been started in November 2020, October 2020. This patient have been evaluated and investigated. So after around 4 months, 4 or 5 months, in March 2021, follow-up PET scan was done. So obviously, in between, even after 1 month of treatment, symptomatic patient was clinically benefit was there. Pain and headache was not there. Dizziness decreased, and patient is almost asymptomatic clinically. And same we can see here in the PET scan. Right upper lobe lesion engaging the right upper lobe bronchus still was there, but significant reduction in the size from around 4 into 3 centimeter size to 2 into 2 centimeter size with SUV reduction to 3.4. And reduction in the right hilar and paratracheal lymph node also have been seen. So there is clear-cut efficacy of osimertinib if we compare with the first generation EGFR TKI in patients, especially if brain mets are there. So MRI brain also have been done in February 2021, and all those lesions which have been found in earlier, which I have already shown you in the previous slide, were gone, and edema is also not there, and it's almost absolutely normal MRI brain in this patient. So complete resolution of the brain lesion on MRI brain, no additional intervention was needed after that. So similarly, there are some other case reports which we may see in the literature. So there are many real-world evidence case reports on osimertinib and brain mets patients. So to be quoted, this case report have been published in JCO Precision Oncology in 2021. It is regarding a 53-year-old patient who already had relapsed on chemotherapy. Initially, this patient have been started on chemotherapy because initially he was in the stage 3A, but on relapse, this patient have been given osimertinib because have been found of EGFR mutation positive. So initially, patient complained of ataxia worsened significantly in the following days and was scheduled for craniotomy and tumor resection. But after osimertinib started, there is significant decrease in the lesion size, which we can see here that this is a large lesion in the cerebellum, and that have decreased significantly, and complete resolution of the lesion have been achieved with osimertinib without any surgery. So in another study, which have been published in Case Report Oncology Medicine in 2020, complete remission of multiple brain mets in a patient of EGFR mutated NSCLC who have been treated with first-line osimertinib, even without radiotherapy, have been achieved. Here, there is left upper lobe mass and multiple bilateral lung mets, and there is around 20 asymptomatic multiple brain mets of around maximum size of 12 millimeter. So after 5 weeks, multiple brain mets disappeared completely, and obviously there was systemic response also. And this case have demonstrated first-line treatment with osimertinib could even achieve complete response in multiple brain mets patients. And those were not 1 or 2, those were around 20 in number. Another study who had demonstrated efficacy in the CNS mets. So this study have been published in Neuro-Oncology Advances. And here also, it was a 3-arm prospective phase 2 study, open label. And overall, 48 patients were taken, either treatment naive who have been treated for EGFR TKI in third generation EGFR TKI osimertinib, or these patients may be recurrent but with T790M mutation positive. So median intracranial PFS was 11.8 months, and osimertinib have demonstrated high efficacy in brain mets. All trial arms displayed a significant decrease in the number and diameter of the target lesion. So coming to main case, and after further follow-up in April 2022, almost complete response have been achieved. So radiotherapy for brain at present in the today's scenario with availability of very efficacious with good CNS penetrability TKI agents with us, radiotherapy is not needed now. Still, patients can get complete resolution in the brain mets patient. There is almost complete resolution of the primary disease also. So no any adverse event were reported in this patient. Patient remains progression-free even after 19 months after initiation of osimertinib. So median PFS I have shown you in the FLORA studies around 19 months, but it's not like that every patient will progress after 19 months. Obviously, this patient even after 19 months of follow-up is still progression-free, asymptomatic, fully active, goes for morning walk, yoga session, and leading a normal life. So because of the excellent response of osimertinib, and so some patients are not very good responder. Some patients shows response and very few patients are not responding at all. So do you have any other biomarker which can predict this much excellent response to this drug? So which have been seen in the future studies, and it is a school of thought. So with this, I close my presentation, and house is open for any query.
Thank you so much, Varun sir, for such a wonderful talk. Is there any question? So there is no question, sir. Thank you so much. From the organizing team, I would like to thank all my faculties and delegate for the joining on today's webinar. For this, I would like to thank you all and have a good night. Thank you. Thank you, Ekta ma'am and support team.
Thank you. Thank you, sir. Thank you, Abhimanyu.
Welcome back.